I think the treatment of malignant brain tumors has always been multidisciplinary if you think about radiation and chemotherapy and surgery. And for the foreseeable future, all of those modalities will likely have a role. Now, as we develop specific, effective, non-cytotoxic therapies, vaccines, small molecules, immune-based therapies, targeted agents, for the foreseeable future, again, those may very well be done in the context of surgery and radiation, plus or minus, the few cytotoxics we have available. I think, as I mentioned before, one of the big approaches, not only in brain tumors, but is, across the field, is can we deliver a therapy that kills tumor cells and releases tumor antigens in the microenvironment, and then deliver a therapy that's designed to rev up the immune system, in the setting where immune cells now and presentation cells will now have antigens to find and present and set up an effective anti-tumor immune-based reaction. And again, that comes down to, are there tumor antigens that really are specific to the glial cells, and that will lead to the kind of specific cell kill, leave normal glia and neurons alone, but target the tumor cells. And so it's certainly quite possible that as our therapies get more effective and we're able to bypass the blood-brain barrier and deliver things, we might see more toxicity. And we're going to have to learn to understand that and mitigate that. But if we're getting more treatments into the brain, we have to worry, and we have to assess what damage, if any, those treatments are doing to the surrounding normal brain, which are adjacent to the tumor cells. And that's okay. I think we're cognizant of that concern. We've faced it with the few agents that do get into the brain and are useful to treat for many years. And it's just going to be the price of sort of having more effective therapies is, moderating and preventing the toxicity to the normal cells. So I do think for the foreseeable future, in most of our tumors, combinatorial therapy in multimodality therapy is likely going to be the way we go. We've had, select successes with targeted therapies or single agent approaches. The IDH inhibitors we talked about earlier. There is data on BRAF inhibition with one or dual BRAF-MEK approaches in some pediatric tumors and adult tumors that express BRAF, some of which are gliomas and some other tumors as well. Involved at the team that published work. Dr. Bastianos is the lead author in the New England Journal on using BRAF inhibitors to target papillary craniopharyngiomas, a very uncommon tumor that's actually outside of the blood-brain barrier, but in the brain, and showing incredible effectiveness with that single modality approach. So I guess in the situations where brain tumors mimic treatable systemic tumors that have a driver mutation that we can target, we may get away with sort of limiting our therapies in certain circumstances to that. But at least for the common brain tumors like glioblastoma, right now there's not a hint that we're going to be able to get away so simply, and we're going to need more complex and multimodal approaches.